Hi there and welcome to the dermatology series. In this we're going to be breaking down different dermatology conditions and this week, firstly to start off, it's going to be psoriasis. So psoriasis is a common, it's chronic, it's a relapsing inflammatory skin condition and affects many people. Now psoriasis itself is a T-cell mediated autoimmune disorder and there is an equal distribution roughly between male and females. When we look at the people that are affected with psoriasis, we see that there is typically a bimodal age distribution, with most people being affected when they are 15, or rather diagnosed when they are 15 to 25 years old, and then when they hit 50 to 60 years old. Now, in the majority of cases, psoriasis is diagnosed before someone is 35, and it's pretty rare to see in children. As you can see, there's a picture here of psoriasis. Now, this is actually plaque psoriasis, and it's got that very characteristic scaly kind of silvery look that you can see here on top of a kind of plaque of erythema. Now there's different types of psoriasis, and the most common one that we just saw in the picture there is plaque psoriasis. Now plaque psoriasis accounts for 90% of the psoriasis cases, and therefore that's what we'll be discussing more on later. Now diving in a wee bit to the different types, so we've got plaque psoriasis, which we said is the most common type. Then we move on to guttate psoriasis, which is something typically occurs 7 to 10 days post streptococcal infection or a upper respiratory tract infection, usually viral. Now this kind of comes as a kind of teardrop shape that you'd see on the skin, and it's more common in children and young adults. When we move on next to pustular psoriasis, we see this is a widespread, tender and red skin with small pustules, and this is seen on the flexures and genitalia. Now if we look at pustular psoriasis in contrast to plaque psoriasis is characteristically found on the extensor surfaces, whereas pustular psoriasis is found on the flexure surfaces. Moving on to another type of psoriasis, which is palmoplantar psoriasis. This is found on the hands and the feet, and moving on further onto erythrodermic psoriasis, this is a very red skin, very fine scale, and this is associated with pain, itching and inflammation. Now, the last type of psoriasis is psoriatic psoriasis. Now, this is associated with HLA-B27 and penicillin cup deformity seen on the x-rays, and this is very characteristic of psoriatic psoriasis as well. Now, it affects the distal joints, and actually the nails are strongly affected as well. There are different terminology which is associated with psoriasis. Now T1 and Th17 are the T helper cells that are associated with psoriasis. Next is epidermal hyperplasia. This is simply an increase in number of cells within the epidermis. Moving on to the next term, which is hyperkeratosis. So this is thickening of the stratum corneum, which is the most outer layer of the skin. Moving on, which is parakeratosis, which is basically the retention of the nuclei within the stratum corneum, and neutrophils are also seen. This is very much characteristic of psoriasis, where there's abundance of neutrophils within the skin. This can be compared to atopic eczema, where in fact there's an abundance of eosinophils. So this is something to note, the difference between both of these. Presentation of psoriasis, how does it present? Now, the chronic plaque type that we were talking about earlier on, this presents as a very red, well-defined, scaly plaque. There's itching, and it's usually found on the extensor surfaces, as we said, for example, behind your elbow. Scale is associated with this as well, and it's got a silver-like colour to it. Moving on to the nails. Now, the nails are commonly affected within psoriasis, and examples of things that can affect the nails is pitting. So pitting is when you get small depressions of the nail surface, and this is basically due to a defective development of layers of the superficial nail bed. And then we move on to another thing that affects the nails, which is oncholysis. So this is a painless detachment of the nail from the nail bed. Moving on further to subungual keratosis, and this is basically when we get scaling underneath the nail due to excessive proliferation of keratinocytes. Now, there's also dystrophy, which isn't mentioned here, but this is basically when your nail becomes basically destroyed, partially destroyed. Moving on further, a thing that's commonly associated with psoriasis is the Kimner phenomenon, which is when the psoriatic lesions appear at sites of trauma. Often new lesions appear at sites of injury or trauma on the skin, and this is usually 2 weeks after that area has, had the damage done to it. Another sign that we see is Auspitz sign, which is basically when the scales on the psoriasis come off, and then there's little bits of punctate bleeding spots that appear, and this is a sign that's also associated with psoriasis. So psoriasis is normally a clinical diagnosis, and very rarely we will use a biopsy to confirm the diagnosis. Now, moving on to the management. Now, we've got a detailed breakdown of the management here, and most patients are given emollients to try and reduce the scale and basically improve the itch. And as we move on further to the first, second, third line, we see it's basically a mix of corticosteroids, vitamin D analog, and also coal tar. The difference is simply the frequency and the potency of the corticosteroids, but that's all listed here, as you can see. Now, if we go further on, we see that if these kind of treatments don't work, we can then move on to things like phototherapy, broad IBI and or narrow band, as well as UVB light. Now, if this doesn't work even more, then we'll move on to will be systemic biological therapies. Now, I think an important thing to remember with psoriasis is it's not just a condition which affects people physically, but also mentally. A lot of people feel quite self-conscious of their psoriatic lesions, and therefore it's really important to make sure that your patient is okay mentally as well, because these things can affect patients. Okay, so I hope you enjoyed the first dermatology video where we covered psoriasis. If you have any questions, any feedback, please leave a comment below, and don't forget to like and subscribe, and please share to anyone that you think would benefit from this. Thank you.